So now the next topic for discussion in removable partial dentures is principle involved in removable partial denture designing. So before we start studying about the various parts like the major connector, minor connector, direct retainer, indirect retainer, right? All those various parts of an cast partial denture. Before that, it is important to understand the various principles which we are going to imply to design that cast partial denture. That is very much important, right? And along with that, in the next counterpart of this lecture, we'll also discuss about the philosophies of designing an removable partial denture. So pertaining to this class, we'll start first with the principle involved in removable partial denture. So now when we talk about removable partial dentures, right, there are two types of forces which will act on a removable partial denture. Those two types of forces are, first is the mechanical force and second is the biological force. So there are two types of forces acting, mechanical and biological forces. Okay, mechanical by the functional activity and biological by the tissues. Okay, so now between these mechanical and biological factors, okay, or forces, right, there should be a balance. Okay, there should be a balance between the biology and the mechanics. Okay, that is where the prosthesis becomes successful. So in 1956, A.H. Smith was the first one who came up with the principles of fabrication of a removable partial denture. It is good if you remember this, A.H. Smith. Okay, so now he gave 5 points. Okay, what are those 5 points? First, he mentioned that it is very important to have knowledge about the biological as well as the mechanical factors. Okay, and along with that, the various forces which are related to that factors and response of the tissues towards that forces. Okay, so three things. First, you should have knowledge about the biological as well as the mechanical factors. Secondly, which are the various types of forces acting on an RPD and what is the response of those forces by our tissues. Okay, second thing was thorough examination and diagnosis should be done. So a proper examination of various parameters which are required to plan and design an RPD and an accurate diagnosis should be given. Third, you should examine properly and do whatever the modifications, right? We have discussed about incomplete dentures, we discussed pre-prosthetic like mouth preparation. That is, before we start the treatment, there are several things which have to be evaluated and then modified based on our design of the prosthesis, right? So in the same way for RPD also, various modifications which are necessary should be done. Next is, it is important to restore the form, function and aesthetics without compromising on the health of the patient, right? So always keep in mind whenever we are fabricating a prosthesis, it should restore the form, function and aesthetics without compromising the health of the patient. And lastly, once you are done with your treatment, regular recall and review should also be done so that you can evaluate if there is any harmful effect happening due to that prosthesis. Okay, 5 points: knowledge, thorough examination and diagnosis, examine properly and do necessary modifications, restore the form, function, aesthetics and regular recall and follow-ups. Okay, so now there are various principles which are involved in functioning of a removable partial denture. Okay, for that we need to know about three things, as I mentioned in the first point given by A.H. Smith, that forces acting on the dentures, response of denture to those forces and design modifications or methods so that you can limit those unwanted or extra forces which are deteriorating the health of the tissues. Okay, so forces acting on the denture, response of denture to the following forces and design methods so that you can limit those forces, right? So first thing, we'll start with the first one. What are the different forces acting on the denture, right? So broadly, if I say, there are three types of forces: the occlusal force, the force from the surrounding musculature and the force from the tongue, right? There are three places from where the force can act, either by eating, chewing or by functional movements, that is the occlusal force. Similarly, during those functional movements, the surrounding musculature on both the sides might generate some forces, and inside, on the inner side, we have tongue. So tongue also moves and generate a small magnitude of force, right? So from all the three sides there are different forces acting. Now when we talk about the occlusal force, this acts mainly on what? Very simple, the occlusal surface. When it acts on the occlusal surface, obviously the tissues are soft and resilient, right? So it will tend to push the prosthesis towards the tissue or the edentulous ridge, and forces which will be of higher magnitude, right, which are intolerable by the edentulous ridge, those forces are going to lead to residual ridge resorption. Okay, first thing. Second, force from the surrounding musculature. Okay, that is mainly from your lips and the cheeks. Okay, these are usually compensated by the forces from the tongue from the inner side. Okay, so the forces from the lips and forces from the cheeks are usually compensated by forces of the tongue, which are acting labially and buccally. Labially in front, buccally inside. Similarly, the surrounding musculature makes forces towards labially and buccally inwards. Tongue causes the forces to go outwards. So those forces are counteracted and they are well balanced. But if they are not, then excessive forces might lead to displacement of denture in both the scenarios. Okay, so the forces from the lips and cheeks, forces from the tongue, and forces from the occlusal surface, right? Balance between these forces will create a dead zone of nil force. So when there is optimum balance between the occlusal force, the surrounding musculature force, and the forces from the tongue, that area, that point where all the forces are neutralized, that point is called as a dead zone or a zone of no force. You can also call in prosthodontic terms, you can call it as neutral zone, or other names like zone of minimum conflict or zone of equilibrium. Correct? So this is a simple concept which we need to understand. Now there are various factors which are going to influence the magnitude. Magnitude is the strength of the force, whether it is more or less. What are those factors that might increase or decrease the forces acting? Okay, so first is the length of the edentulous span. So if your length of the edentulous span is more, right, then the force is going to be directly proportional on the abutment teeth. The more number of teeth you are replacing, the more amount of forces will be acting on the abutment. Okay, very simple example. For instance, you are having a vehicle, a four-wheeler, right, a car, where there is a capacity of accommodating 5 people. Okay, that is your edentulous span. Your 4 tires and the suspension and everything are the abutments of your car. Okay, so now in that case, if you try to make 15-20 people sit here and there on the top of the car, on the side, everything, like if you overweight the car, what will happen? As the number of people are increasing, the force on the abutment will also increase. Very simple. Similarly, the more number of teeth you accommodate, the more amount of forces will be acting on the abutment teeth. Okay, so what we should try? We should try to preserve as much as number of posterior teeth we can, because that are the ones which are going to withstand the majority of your occlusal force. Okay, so if you have a posterior teeth support, that becomes a very good situation for you as well as for the patient to give a removable partial denture, and it might be a successful treatment. It will be a successful treatment if not also, but the forces will be more. You need to think twice before planning the prosthesis. So that is the first point. Second, the quality or the support of the ridge, the quality support of the ridge. Okay, so if we say that there are large and well formed ridges, obviously large ridges will absorb forces in a greater magnitude compared to a smaller or a thin or a knife edged ridge. Correct? In the same way, if you have a broader ridge with parallel sides, suppose if the ridge is broad as well as, and it is having parallel sides, these two sides are parallel, in that case the horizontal stability of the prosthesis will also be more. The prosthesis will very minimally tend to move in a horizontal plane, right? So that is, it will impart more amount of stability to the prosthesis. Third is thick mucoperiosteum, right? So if you see that the mucoperiosteum or the thickness of the soft tissues or everything is good, obviously it is going to provide good amount of support because it provides a good cushioning effect to the underlying bone, okay, where all the forces are going to get directed. Okay, so the quality support of the ridge mainly by the structure of the ridge as well as the overlying soft tissue over that ridge should be kept in mind. Then what is the response of the oral structures to the previous stresses? Okay, in that case the periodontal condition of the remaining teeth should be evaluated. If you feel that the 4, 5, 6, 7, that is 2 premolars and 2 molars are missing, anteriorly you have a moderate periodontal support, the teeth are not so good periodontically, but still they can withstand the force. But if you splint them, so what happens individually, if you keep the teeth, they are going to have their own strength. But when you are going to splint the teeth, join all them together and then give a prosthesis, in that case they get strength of each other and they are better in handling the forces. Okay, so if there is a need of splinting, that also has to be done. Then amount of abutment support remaining. Okay, so what is the amount of abutment support which is there, that also should be kept in mind, because all these 3 points are going to affect the prognosis of the teeth. Okay, then fourth is the occlusal relationship. Now there are few teeth in the oral cavity when you are thinking of a removable partial denture, right? So in that case you need to evaluate the occlusal relationship of the remaining teeth, the orientation of plane of occlusion, how is the occlusal plane. Okay, so now if I say the amount of forces acting on the natural teeth is somewhere averaged around 300 pounds, whereas amount of forces on an artificial teeth are 10 times less, that is around 30 pounds. Okay, so you need to keep in mind the area of denture base which is against the occlusal load will determine the stress on the abutment and the tissues, and you need to take care that all the stresses are directed towards the crest of the ridge. Suppose if there is any poor occlusal relationship, okay, then there might be a supra eruption of the teeth which will occur in the future or might have occurred. So these points also should be kept in mind. Then the qualities of the clasp. Now see, clasp quality varies based on the material which you are using, right? Every material has its own flexibility. The clasp should be flexible to an extent so that it wraps around the teeth and goes and locks over there, right? So if I talk about a wrought wire clasp, okay, so when I talk about a wrought wire clasp, they are more flexible. Okay, the forces on the, but as they are more flexible, there are less amount of forces which will be directed on the abutment teeth, right? But the forces on the ridge will increase. Why? Because the clasp is more flexible. There might be chances that the RPD might move a little bit to a small magnitude, right? In that case the horizontal stability is going to be less. Whereas if I talk about the nickel chromium or the cobalt chromium clasp, they are not as flexible as your wrought wire clasp, so the forces on abutment will be more, but there will be more horizontal stability. Okay, then the clasp design. Now always we have been told in our practicals that the clasp should have passive fit, it should have a passive fit, it should engage smoothly, it should not get stuck in the undercut, right? All those terminologies we have been hearing. So passive fit means a clasp which just passes through the height of contour of the teeth or an abutment, okay, and then engages over there without causing any harm to the abutment or without overlaying any unwanted forces on the abutment teeth. Okay, so there are some considerations or in terms of the reciprocal arm and the retentive arm of the clasp assembly, right? When we study about direct retainers, we'll study about this property or this design more precisely. So for now the reciprocal arm should come in contact first while insertion of the prosthesis. So suppose if we see from a side view, this side is the reciprocal arm, here with red I will draw the retentive arm. So this should be the first one to contact when you are placing the RPD, and then this should come in contact when it is at the most prominent part. So when it comes in contact at the most prominent part, the retentive arm, it exerts forces in this direction. So to counteract those forces, the reciprocal arm should always be present prior to the retentive arm, so the forces are contraindicated and they are balanced, right? That is the whole concept. Okay, so that is why it is important to design the clasp assembly in such a manner. If there is more active fit, obviously it is going to impart more forces on the abutment teeth.